committees. She is very involved with Region 5 Office of Minority Health Initiatives and Programs and is the current president for the National Association of State Office of Minority Health. Minority health is very near and dear to Ms. Holt, and she makes it her personal mission to educate everyone on the importance of equality health care for all. Our second presenter is Jeremy Turner, who currently serves as the director of the HIV STD Viral Hepatitis Division at the Indiana State Department of Health. Jeremy entered the field in 2004 as a community health educator and grassroots HIV activist. His experience with homelessness after coming out at the age of 17 shaped his passion for working with marginalized populations to address both medical and supportive services needs while acknowledging the social determinants of health play a vital role in achieving successful health outcomes. During his time in the field, Jeremy has worked across the entire spectrum of HIV services, including prevention testing, housing, case management, and development communications, before transitioning to serve as Deputy Director of the division at ISDH in 2017. In August of 2020, Jeremy will be celebrating his 16th year of public health service. In his personal life, Jeremy performed fellow summers to raise funds for HIV, youth homelessness, and other important issues to the LGBTQA plus community. Jeremy was awarded the title of Miss Gay Indiana in 2010 and also served as president of Indy Pride from 2017 to 2018. He is a former board member for Team Friendly Indiana, which is an organization designed to help address HIV stigma, and skills and education presenter at many local events. We thank you both for being with us today. So I will turn it over to now Jeremy and Antoinette.
Thank you very much, Gwen. I want to get the formalities out of the way so then I can be like, whoo. And so me and Jeremy are nice, wonderful people. We're gonna give you the facts, but we're not gonna make it to where you start dwindling off and drifting off or sleeping on us. Am I right, Jeremy? Yes.
You got that, yeah.
All right.
Thank you for having us today. Antoinette's going to guide us through the CLAS standards. I'm here more of a subject matter expert representing the community that I'm a part of outside in my professional capacity. And so Antoinette helps us out internally, even through my division, to make sure that we're all up to snuff on items like CLAS standards and all kinds of different diversity and inclusion trainings that we host here at the State Department of Health. And it's great when she and I get to team up like this because this is a presentation we've never done together before.
Oh, so anything can happen. Yay. All right, so again, let me thank DMHA and TechServe and Engaging Solutions and everyone that's been involved. We appreciate the opportunity to be able to come to you. And again, if you have any questions, just let me know and we'll get started. Okay, so our goal today is to give you a clear understanding of CLAS standards, as well as a little bit more guidance and understanding of the LGBTQ questioning population in regards to the disparities that they face and risk factors and health outcomes. We hope that by the time we finish our training, you will have some risk factors that you will know that contribute to health disparities within this population. Hopefully, we're going to do lecture and PowerPoint and hopefully get you engaged so then you can be a part of it. And then also, we want to make sure that you are, again, familiar with CLAS standards. That's why we provided you a copy of it. If you see me looking to the side, my notes to the side, so I'm not ignoring you. And then also case study scenarios discussion, because we want to hear from you. I know a lot of times people talk at you, but we want to make sure that you are internalizing what you have so you can better serve the communities that we're addressing. Okay. All right. So what I will begin to ask you is, what is your purpose? What is your purpose in regards to being here? Not so much that it was mandatory, but you wanted to make a choice. What is your purpose in regards to the service or intent of your job that you provide? What is your job responsibility? What are the goals that you have in considering? And the reason I'm asking you this is because this helps, in essence, just doing a self-assessment of what can I do in order to be better? Who are the people in the community in which you're trying to serve, the potential group that you're trying to serve? Who are the people that you serve? It's so important to know the communities or the target population that you're trying to reach. Do you know their cultural norms or values? Do you know the gaps that they have, or are there gaps in regards to benefiting from the services that you provide as mental health providers or technicians or experts? So those are some questions to ponder as we move forward. I know that you've been in this wonderful series, and of course, experience have taught you the negative attitudes and effects as far as discrimination, social isolation being one big proponent of it, depression and anxiety. It can lead to or down the road as far as poverty, a chronic illness because stress can take so much precedent over the body. It can cause different things to malfunction in our bodies. Delayed care seeking because of past experiences is like being in a bad relationship. You know, you're bringing on that luggage or those experiences with you. And so that can delay me from seeking the care that I need or different things. It can lead to where I don't have an appetite. It can even lead to me dying earlier than intended. So these are some things that we want to consider. I think, and then Jeremy can chime in too, the LGBTQ population is a vast, diverse population. So this is a population that can incorporate all manner of differences, race and ethnicity, religion, socioeconomic status, education, different things. This takes part not just in the United States, not just in Indiana, but all over the world. Cultural differences, it changes from day to day within. Jeremy, did you want to say anything right here?
I'll just chime in with this. And one of the things as providers, as service providers, it can be really challenging for us to all know where we are with who identifies as being part of our community. And I say that even as being a past president of one of Indiana's largest nonprofit organizations that serves the LGBTQ plus population as with Indy Pride, it's a struggle for me even being immersed in this every day. Obviously, in our division, working with populations that are disparately impacted by HIV. These are communities that I've been serving for 16 years, most of that on the front lines, and then now here at ISDH, and then in the community, both as a person who is part of the community, who works with people who are gender non-conforming, Indy Pride, all of those things, it's even hard for me to stay up on. And so I think that one of the most important things as we move through the presentation today and as we talk about serving folks who are part of my community and our community that we share together is that it's okay to be vulnerable with people, and it's okay to say that you aren't familiar or you don't know. And then just to, be open to receiving that kind of feedback about learning how people identify and embracing that. So that we can be effective service providers for them. And we'll get into that more later, and I'll give some examples of things that I've done during my tenure here at ISDH to help align us as state level service providers and meeting people where they are, while at the same time satisfying the funder requirements, most of which are federally required elements, that we have been able to mitigate some things that allow people to be seen, but also allow us to do what we need to do on meeting metrics and performance measures and all those kinds of things.
Okay. Thank you, Jeremy. So as we go into cultural competency, generally CLAS et al. Is usually the standard definition of what most people use when talking about cultural competency. I just want to just reiterate the importance of involving cultural competency in all aspects of what we do, whether it's policy making, administration, our practice every day, the service delivery that we provide, systematic changes that need to be made. We have to value diversity, and we have to do every now and then that self-assessment and adjustment in regards to what am I doing to aid or hinder the progress of our agency or organization. Manage the dynamics of difference, embracing difference, appreciating difference, even knowing how to utilize or work with difference if it goes against maybe a belief that you have or different things, how to treat everyone with common respect. Acquire institutionalized cultural knowledge, continuing to have training such as this that's being provided to you, taking advantage of it, and adapting these cultural contexts and people within your current system. I'm going to say it over and over probably in this presentation that partnership is key and important, and involving the people that you serve is very important in the dynamics and things that you do. And if you don't have them at the table presently now, then how are your programs and things going to be successful? So these are just things to consider when looking at cultural competency. Because again, despite of decades of attention and awareness in healthcare and disparities, continue to persist across the board. And so that's why we've created CLAS Standards. CLAS Standards originally was created in 2000 by the Department of Health and Human Services. CLAS, of course, meaning culturally linguistically appropriate services. We want to ensure that we're providing health equity to all and reducing those health disparities. And that's the beauty of CLAS Standards. So CLAS Standards has 15 action steps that are intended to advance agencies, individuals, and health equity. Want to improve quality, again, eliminating health disparities. It serves as a blueprint for your organization, as a guide in regards to what you can do to make sure that you're providing culturally and linguistically appropriate services. Okay, so culture and language are vital factors in regards to what we do and how services are delivered. And so providing these appropriate services helps us to be able to impact outcomes. So it's going to allow us to be able to have better outcomes for those individuals that we're serving. They get choices, we're empowering people, and those different things. And so that's what CLAS does. So CLAS is about respect and responsiveness. If everyone had the solution in regards to knowing every culture and everything, we will all be sitting on the beach. Of course, we would be COVID-free and we would just be enjoying life, but that's not the case. So we want to make sure that everyone in their mindset is prepared to offer respect and responsiveness, because that's basically what gets you a lot of places and a lot of successes. And then respond to an individual population's health needs and preference. Okay, not so much what we want or what we've learned or what we've been indoctrinated to do, but again, ultimately helping to reduce health disparities and achieve health equity. We want to ensure those individuals that we are serving have the right things. So implementing CLAS standards is going to allow you to gain the knowledge of cultural values and beliefs. It's so important just to engage yourself in different cultures, to understand in regards to your patient as far as where they're coming from, interact effectively amongst people, provide quality care that is respectful and not necessarily judgmental, and then delivering the proper healthcare services and supports, making sure people have their primary language, making sure people are able to, because sometimes it's not always just language, it's also not spoken word, but we have a segment of the population that are that need American Sign Language, or we have a segment of the population that may need Braille or different things like that, those with disabilities or different challenges. So we want to make sure that we're providing everybody their needs and identify and respond effectively to the preferences of the populations that we're serving. So we will begin with the number one standard. Woo, one down and 15 more, 14 more to go. All right, so hopefully everybody is with me. So number one standard, again, we're providing effective, understandable, respectful quality care. And so how we ways that we can implement CLAS number one is acquiring the knowledge about the cultures and the languages that people you're serving are in need of, collecting the data of cultural beliefs, finding out, engaging, if it's someone that has a Native American background, if they're providing services, would they prefer their medicine doctor to be there? Is there particular ritual things that they have to do? Do they come and smudge before they begin to enter into a session with you? So these are things that you have to consider. Periodically, you want to make sure that you're collecting data, or maybe have a survey, a web application, get feedback from the people or the that you're serving. So these are just ways that you can implement, but the principal standard of CLAS is number one, is providing that effective, equitable, understandable, and respectful quality care of services and making sure that you're meeting the needs of those that you serve. Okay. So CLAS is divided up, I'm sorry, I should have said that in the beginning. CLAS is divided up into 4 areas. You have your principal standard, you have your governance, leadership, and workforce, which will be the next couple of strategies. And then you have communication and language assistance. And then the last couple will be engagement, continuous improvement, and accountability. So the next set of strategies that we will go to would be standard number 2 through 4, which is looking at governance, leadership, and workshop. So we want to advance and sustain organizational governance and leadership to promote CLAS standards. Number 3, we want to, so what does number 2 look like? So we want to identify and develop committed champions, those people that are going to be leaders that will push for the cause, that are going to continuously make sure that vulnerable populations are being represented at the table. They're going to ensure a commitment to culturally competent care. Hopefully these leaders are going to help to recruit and retain and promote at all levels of the organization leadership that should reflect our target population. I know that's something that we're working on at ISDH. And then develop a plan that will be effective. Standard number 3, again, going back to recruiting, promoting, and supporting culturally linguistic diverse governance of leadership. How do we do that? We want to make sure that we collaborate with stakeholders on finding the necessary people that could be great assets to our company, continuing education opportunities for our staff and people. Those things make a difference. Make sure those job notices that you are promoting or may have are out to the general public so people know what's available. So that is one way that we can look at in regards to the governance leadership. We want to include support from clinical and non-clinical staff, having those quote unquote cultural brokers, promoting diverse staff members, appreciating everyone's differences. Those are portion part of how we can incorporate the third standard for CLAS. Sunny will let me know if there's any questions. So I'm going to keep going until then. CLAS standard number. Okay. You said yes, there's a question?
Sorry, no questions yet.
Okay, thank you. All right. CLAS standard number 4 is involving educating and training in regards to leadership and making sure that it's an ongoing basis and process. So again, we want to make sure that we provide cross-discipline training, utilize internal and external resources to educate leadership. It cannot always be a top-down approach in regards to what we do. We want to make sure that we have a top-down, bottom-up. Everyone's coming together to ensure that we have the same vision and goals that will achieve health equity. We want to address cultural competency as a routine, not just so much we have this training and it's one and done. That's not going to work. We want to make sure there's a constant opportunity for us to be able to benefit from that.
And Antoinette, if I can just jump in here, just to follow up on what you just said, you know, when you're creating that culture in your workplace, that's what it really takes. And I think that as we talk about the massive diversity in the LGBTQ plus community, you know, that culture is so important. And oftentimes we as leaders, whether we're talking about, you know, just being an office manager, or if we're a program manager or a director of a large facility, we can have goals and ideals that we have and that we might share with the upper echelon. But, you know, when people walk in, a lot of times their first interaction at places is with that receptionist or maybe even with a part-time volunteer. And so when we're talking about being effective service providers, keeping people engaged and retained in care. Their interaction with that lowest level person in the organization can affect their entire care experience and could cause them to disengage. And so when we say it's not a one and done, we talk about that diversity and how it's impossible in one training to cover all of those different items. And then when we talk about engaging at all levels of the organization, from volunteers all the way up to the CEO level, I just want to reiterate the importance of that. And I think that this particular topic today helps to reinforce how that's what it's going to take if you're truly going to be effective.
Right. Thanks, Jeremy. And we can get in regards to later, in regards to, since this portion was on governance, leadership, and workforce, we could talk about action steps possibly that leadership can do that would, hopefully help an agency or organization. For example, leadership can be aware of national initiatives that involve the LGBTQ population on health, or they can incorporate non-discriminatory policies, making sure that they're including sexual orientation and gender identity. So these are things that we want to make sure that we're continuing in regards to our efforts as far as incorporating CLAS standards in what we do. The next portion of CLAS standards or section is focusing on communication, language, and assistance. And so CLAS standard number 5 is making sure that we offer language assistance to individuals at no cost to them. And again, it's law, so Title V, the Civil Rights Act, the American Disabilities Act, all these different proponents, if you're receiving federal funding, if you Medicare, Medicaid, all these interested proponents are making people obligated to provide the necessary linguistic and cultural appropriate services to those people that you serve. So offering language assistance to individuals who are limited English proficient, or what we consider LEP, at no cost. And so how do we do that? Again, there's some people that conduct assessment as far as languages, so you know what are the needs of the people that you treat. And again, as I mentioned before, not just so much spoken language, but if you have to provide communication via for those people that are hard of hearing, or those individuals that may be blind, you want to make sure that you're incorporating that, ensure that the access to these services that you have. A lot of places that you will go now, and you may even have this in your organization, where when you come in the front line, you have a sign that says, what language do you prefer or need? Ensuring the medical orders and the patient education, making sure that you have the appropriate interpreter. All these things fall into the implementation portion part of offering that. CLAS standard number 6 is making sure that we inform people of the availability of providing these services. And so we can do that, again, like I said, with signage, opportunities where you can let them know when you are dealing with them, engaging with people, that these are the services that we can provide for you. We perish because of lack of knowledge, and everybody does not know certain things are available. They don't know times and hours. They don't know the programs that you're offering, these different things. They don't know you may have a bilingual staff person, or you are trying to acquire someone. So these are things that you want to consider when looking at communication and language assistance. In standard number 7, we have the competence of individuals providing the assistance, recognizing the use of untrained individuals. We want to make sure that the individuals and people that we have hired or partnered with or contracted with are professionally medical interpreters or trained, qualified bilingual, multilingual staff. When we use the telephone line or the video interpreting technology, we want to make sure that we have a reputable site that we're using, especially for, those, if you're constantly in need of certain set services. You want to develop relationships possibly with your community partners. I have community partners that we meet once a month, our minority health partners, and there are individuals or organizations that provide free interpretive and translation services. And so we try to make sure people are aware of that so they can benefit from it. And so we want to make sure that these people are highly skilled and trained so we don't have the risk of confusion or the risk of detriment to someone. Again, you also want to make sure that the interpreter may be knowledgeable about the subject matter or they have met in different things. And so if you're dealing with, for example, my dear friend Jeremy, you know, he is over HIV, STD, and hepatitis C. So, you know, terms that may be used in HIV and AIDS or for sexual practices or different things or medications, you may want to make sure that your interpreter or the services that you're working are familiar with that. And class standard number 8, you want to again provide that printed multi-materials and media too. We want to make sure that when you are getting things translated, that they are at set levels as far as education. You want to make sure that the particular group or individuals that you're dealing with, the translated materials are specifically in their language. So once, you know, Spanish does not fit everyone that speaks Spanish. You have different countries and people that are represented. There are different cultural norms or different innuendos that may be. So one word may not fit in one setting for one particular target population. So you want to make sure even when you're dealing with our Burmese population, you have different dialects. And so one dialect getting it translated in this brochure is not going to fit all the needs of everyone. Again, it's so important to know who you're serving and working with those communities so you can provide that easy to understand print and multimedia materials that they need and services. So class standard number 9 brings us to our last set portion of class. And so that is the engagement, the continuous improvement, and the accountability. So in class 9, we are to establish culturally and linguistically appropriate goals and policies and accountability. How can we do that? You know, how do we integrate implementation for class in regards to treatment? We need to involve, again, the people that we're serving are different demographic groups. Ensure the plan includes the establishment of goals and deliverables, provision for culturally linguistic appropriate care and treatment, services related to those patients and clients, even their families. You want to involve them in the process of creating these tools or a strategic plan that will help you in regards to managing accountability. How are you going to be transparent to those individuals that you serve? Okay, so that brings us to 10, where you're going to conduct ongoing assessments of the organization to make sure that you are class relative and class standards. You're going to continue to do create instruments, tools, find data sources. You want to make sure that you're doing some type of internal auditing process or an evaluation that's going to allow you to be able to make sure that quality improvement is always in progress. You know, you want to make sure that your personnel, whether or the resources that you're allocating the money, you know, it's real easy to say, oh, we want to make this change. Oh, we want to do this. We want to do that. And you don't have the money to back it up, or you're not providing the resources to back it up. I always tell people sometimes that they sell minority health and health equity cheap. You know, it's always trying to find the lowest price or discount in regards to providing these services rather than investing in the necessary resources that you need in order to be successful. And so I think, again, when you're looking at implementation strategies for conducting ongoing assessments, it's very important that your organization or even yourself be vested in what we do. Okay, and then sharing those findings so we can create best practices and opportunities. Standard number 11, we want to continue to maintain accurate data and reliable demographic data. You know, we just don't want to go by, we should not be using data that was 2002 and outdated. You know, this year is a census year. Hopefully everybody's done their census. I think we had to do it by yesterday. They may have extended that, but census affords us that opportunity to know the areas. I know you've seen the commercials, but it's so true. This is the data that you receive. This is how we determine the population. This is how we determine the needs of what we need to do. And then when you're collecting data of projects and things that you're doing, you're able to show those people that are vested in your organization, or where research is going to come, or when you're applying to grants for the feds, the need in regards to providing these CLAS standards and health equity opportunities in your service delivery. Okay, I think I went backwards. All right. When looking at CLAS standard number 12, we want to conduct regular assessments of community health assets and needs and results to the plan and implement services that respond to cultural and linguistic diversity populations. What does that mean? We want to ensure that our policies and our procedures and the practices that we do are in place to monitor what we do. Again, it's wonderful to go out and do work, but if you're not keeping tabs of it, if you're not doing evaluation of the services that you're providing, it's very hard to show in regards to that quantitative data that you need in order to get the necessary planning efforts in place and support that you need from stakeholders and resources that you need from funding sources. So you want to constantly update in regards to your services and what you're doing. Okay. So 13 is partner with community to design, implement, and evaluate policies and practices. Again, partnership makes the world go around. It is really, truly a small world after all. I hate to be using puns and stuff like that, but it is. And it's so important to have engagement. It's so important to have partnership. And so when you are revising or creating policy and you're making procedures and you're doing practices, you have to involve the communities in which you're serving. You have to have community engagement. You have to have it in the necessary languages and resources and tools that they need. This is going to ensure success. This is going to help you in regards to making sure that you're successful in what you do. Okay. This next one I find is very interesting, is 14, because a lot of people don't usually think about create a conflict and grievance resolution process that are culturally and linguistically appropriate to identify and prevent and resolve conflict. What does that mean, good people? You got to have a plan in place in case something goes wrong. Okay, you want to make sure, as much as culturally competent your organization or you could be, there can be someone that's on your team or someone that you come across that can cause a conflict within the community, that can cause a conflict within your program. And how are you going to resolve it? What are you going to do? What are the action steps if a grievance happens? How will you address it? You can't just shove it up under a rug and just hope for the best. What specifically are you going to do to ensure that your organization has the capacity to be able to handle? You may have to get a third-party person in it that was not involved in the conflict to help you resolve the issue, because once you lose that relationship with that community partner or the individual, it's very hard to get that back. Once something happens, and if you get it back, it's a miracle, but it's very hard. So what do you do to ensure that we continue to keep it where we can resolve something immediately and not let it fester, not let it grow into a grievance, not let it grow into a lawsuit, not let it grow into possibly canceling out or ruining or discontinuing the program? Okay. And then lastly, for the class 15, we want to communicate the organization's progress. We have to be transparent. We have to be accountable to the people that we serve. We have to be accountable in regards to the resources that we receive. So those reports, the presentations, share what you're doing. Go to national conference and present, because you're doing great work. You know what you do day in, day out, which is very important. You know the progress that you made, the changes that you're making in lives. Share that information. Don't hoard it. We're not created to be able to hoard everything. We want to make sure that we're sharing it. We share it across different platforms of media, because, sometimes the good things that are being done are always expressed or shown in mainstream media and different things like that. So we want to make sure that people are aware. So you want to make sure that you're disseminating the progress that you are doing in regards to CLAS implementation. And so those pretty much in a nutshell represent the 15 standards as far as CLAS. So if you don't remember any of the things that I've just said for the past couple of minutes, or the 15 standards that we went over, you want to make sure that you're respectful. You want to make sure you're understandable, you and your organization, that you're effective, and that you're equitable. You want to make sure that you're respectful. You want to make sure that you're understandable, that you're effective, and that you are equitable. And these are things that are going to help you ensure success in regards to those CLAS standards of applying it. So moving forward, again, there's a lot of challenges that we face. So we want to make sure and moving forward that it's not just so much we stop categorizing things, but how we become aware of when we do it. Those biases that I know that you have been trained on and different things, being able to see people for who they are and not necessarily just these categories of things. We respect people and the differences that they bring and the opportunities for us to be able to know, but we want to make sure that we recognize those and not necessarily discount those differences. Okay. So any questions so far? Okay.
No questions, Antoinette, but just a couple of quick facts. We've got over 89, we have 89 attendees, and everybody is glued to their screens from our analytics metrics.
Well, thank you for being glued to your screens. I greatly appreciate it. Looking at challenges that are faced within the LGBTQ populations, there are things that are happening within this population, and then I'll leave room too for Jeremy to chime in too, because I feel like I've talked a lot. The incidences of hate crime and discrimination that exist, the denial of equal rights, phobias, structural norms can create a burden of and added stress and experience of in the health of a person who identifies in regards to LGBTQ. Potential difficulties of getting health insurance, recognizing and acknowledging your partner, possible employment because you may work in an environment that will not be accepting as far as of your life, and limited access in regards to health issues, the data that needs to be collected within the population, mental health problems that exist as far as certain challenges in life can lead to unhealthy coping skills, challenges and difficulties with being open about one's sexual orientation can increase those stress and supports. And again, like we said, negatively affect health overall.
So I'm just going to pop in here, and as we go through some of these bullet points, I want to relate this back to some real life examples that I hope will have some utility for you guys as you're working with folks from this community. One of the things on the first bullet point there, ours is a community that's often born out of trauma. And so when we talk about hate crimes and discrimination, that can look a lot of different ways, and it starts when we're very young. And it continues throughout our entire lives when we are either included because of our tokenism or the fact that we are queer, or we are excluded because of it. And then that bad treatment can run the full gamut. There are physical kinds of hate crimes, and then there is emotional trauma that is endured by our community in a lot of different ways. And so, when we talk about discrimination, particularly, I think it's a good time for us to look at the Hollywood glamorized version of what being transgender means, and then what transitioning looks like for people who are in different stages of their life, particularly if they're older, and how they can present in public and how they are received by the service providers that they're met with. Not everybody can afford to have the kinds of surgeries and procedures that feminize their looks, or that masculine make their looks more masculine. And so, you know, that's definitely something that's endured by our transgender community a lot. When we talk about difficulty in getting or keeping health insurance and maintaining employment stability, it might not be that they can't get insurance, but it might mean that we can't get the kind of insurance that we need to keep us healthy. For example, one of the most important things in HIV care since the beginning of the epidemic was the emergence of biomedical interventions like pre-exposure prophylaxis or PrEP. And when we have people who are working in underinsured conditions that don't cover PrEP or that have extremely high copays, you know, that limits their access to life-saving intervention. And so that's another thing, you know, that weighs heavy on the minds of people. When we talk about limiting access to high quality healthcare, if we're serving people in rural environments, it's important for queer people to be able to go in and share with their doctors about all parts of their health. You know, we have needing to have anal pap smears done on men as they age and making sure that we're monitoring for anal cancer and things that disproportionately impact our community. If you have only one provider in town and they're not knowledgeable about the health of queer people, that can be really troublesome. And particularly if you're dealing with people who are grieving because they've been diagnosed with a serious illness related to something that we're disproportionately impacted by. And then, you know, as we move down and we talked about mental health, one of the things that I really encourage people to read is The Velvet Rage. And I think that that's a book that accurately talks about the duplicitous nature of a lot of us from our youth who had to conceal the fact that we were gay or lesbian or transgender. And what that means is you move through those, you know, formative and developing years of your life when you are concealing your true self and you're projecting something that is the expectation of what people want to see. And then you think about the kind of impact that has on your ability to have relationships with not only your family and friends, but the impact that that has on the relationships that you'll have with significant others as you move through life. And so I think that that also plays into that next bullet point as we talk about challenges and difficulties about being open with our sexual orientation. You know, it really is something I think about a lot when I was young, you know, working in retail when I was in high school and in college, about not being able to even tell people in retail stores during that time. I'm 36 years old. And so we're talking about the early 2000s here, but imagine now with where we are with media, and this is before RuPaul's Drag Race, and this is before Queer Eye for the Straight Guy, and everything was chintzy and cute about gay people on TV, where you could work in a department store, in a large anchor store in a mall, and feel like you can't be open about your sexuality. And so, you know, obviously, as we move in, younger people are facing different kinds of challenges than I did when I was, you know, that age. However, these are the types of things that we've experienced all through our lives.
All right. Okay. Just to the point in regards to what Jeremy just talked about in regards to refusal of care, represents as far as barriers for the LGBTQ community, lack of inclusion in health outreach, lack of education on the risks that affect LGBTQ people. All right.
And Jeremy, we do have a question. We had several folks request the name of the book that Jeremy suggested.
It's called The Velvet Rage, and it's velvet, like the the Velveteen Rabbit, but The Velvet Rage. It's written by a psychotherapist who specializes in providing care to queer men specifically, but I think that the overall book and the message in the book does a very good job describing just overall the impact that our young lives have on our ability to be successful as adults. It also helps to further explain how we develop some of the risk behaviors that make us disproportionately impacted by HIV, STDs, and substance use. I found it fascinating. I just read it myself a few months ago, but it's a book that's been around for a while, but I really suggest it. It's a great read.
Thank you. And we've also chatted the full title and author into the chat screen.
Cool beans. And so just from what's been discussed, you know, bias and prejudice tend to function at many levels, including personal, interpersonal, and even institutional. And so how do we, again, go forward in regards to providing effective care to those patients that we serve in the LGBTQ community? We want to be inclusive as far as our language. We want to be welcoming when patients discuss their relationships with sexuality and gender. You want to avoid over pathologizing. I can never say that word right. And you want to avoid under pathologizing and provide a safe and affirming environment. You want to empathize with your patients, again, providing that respect that we talked about in the beginning when we were looking.
And when we're talking about, just as we're talking about using that inclusive language, this is something I even struggle with, and I know that many people do when we're not accustomed to it. When you're working with queer folks, it's really good for us to get out of using pronouns, or we want to use gender neutral pronouns. So we want to use they and their, just because we have so many people who fall across the gender spectrum and identify in so many different ways where, you know, it's not just male or female, and it's not just people who are cisgender males transitioning to be transgender females or vice versa. We have people who are considered non-binary, and that misgendering people is the stepping off immediately on the wrong foot when we're trying to be service providers for them. And so just that in itself is one of the big things that I see happen so frequently and that I do myself. But then, you know, once you do it, if that's fallen out of your mouth and it's fallen out of mine so many times, just immediately, you know, provide a brief apology and move on. You know, and that's the same way across all of this kind of stuff, is that, you know, we need to acknowledge when we've made a mistake, but also not let that prevent us from kind of moving forward and setting us, you know, down a different path.
Excellent point, Jeremy. I think in regards to just moving forward, just some things in staff behavior, some things that we can be aware of, some triggers or things that could lead to having issues, constraining the client's exploration as far as self-discovery. You know, they may share something with you, but no, this is how it really should be, and all these different things, you know, employ invalidated interventions or therapies, expecting clients to conform to the clinician's belief on how LGBTQ should be, making assumptions about a person's values or lifestyle, romanticizing. I think Jeremy talked about, or positively stereotyping people can distract you as a mental health provider. Being unprepared. My computer froze. Being unprepared or unable to have in-depth discussions with your clients, absorbing and mistakenly applying stereotypes and prejudices, you know, what you thought or what this should be, or this is what I've known, or different things that people do that are even triggers in regards to how we speak or what we say. You know, or I have a friend, or, you know, I have a lot of gay friends, or these different things like that. And they do this across certain variant diverse populations, but you know, these different things that are triggers that could cause problems. Assume or believe that someone's identity is a symptom of mental illness, assuming in regards to that sexual orientation or gender identity is the core problem in regards to of what they're doing, but you would never do that with your heterosexual clients. Things that you would ask one set population that you would never ask another individual. You just got to consider, overlook that. Again, like we had said in the beginning, that your LGBTQ population represents such a diverse range of cultures and people and individuals, and it's ever changing. So believing that being gay or lesbian or bisexual is no big deal and you're avoiding the real issues, these are just some common lapses in regards to staff behaviors that can happen.
But, and I love this slide because one of the things, and you all as mental health providers have dealt with this kind of behavior on that first bullet point, unable or unprepared to have in-depth conversations with client about their gender or sexuality. In the same way that people who have other types of lifestyles and behaviors are going to test you about seeing how much you can tolerate or try to shock you into not being to kind of see if you're able to handle who they are. We will do that with service providers. And, when you're dealing with people who've lost their entire family due to coming out and due to their sexuality, they're not going to be afraid to, try to test you in your initial appointments about seeing if you can handle, hearing about who they really are. And any kind of facial reaction, any kind of negative response is going to cause them to want to disengage from care. When I used to be involved in the nonprofit I worked for before, we had a team of mental health counselors and psychotherapists that were working with our clients. And, I think that that was really, really common upon intake. And then, kind of following through, I think that the stereotypes and prejudices bullet point works for, on its own. But when we talk about assuming that their queerness or their LGBTQ plus, I'm going to just use queer for me because that's a term I'm comfortable with, and that's something that is saying all those letters over and over, and acknowledging the fact that if you look at the entire list of the letters in our community now, it's so long I don't even know who could remember all of them. But anyway, when we talk about that, when I was young, my mom was a nurse and she worked in mental health, and she could identify that, I should probably speak to someone. And the therapist, every time I would go, I wasn't even out to myself yet, but he kept on referring to the fact, asking me if I was gay, relating things back that I was experiencing to being gay. And I wasn't ready for that. And that was not an effective way to work with me, but I think that he was using stereotypes about what was going on and trying to get me to come out rather than to talk to me about the things that were impacting my life to make me feel the way I was feeling. So I think that that's, something I really like to talk about and bring up from my own past experience. And then, I think that particularly when we look at that last bullet point about believing that being, queer is no big deal, and that clients who want to talk about sexual orientation are avoiding the real issues. I haven't felt that necessarily, that anybody's ever treated me that way. But, just the same way as we talk about, there is no trauma Olympics, but then we don't get to define what is on the other end of that spectrum, what causes people trauma. And so, I know that you all know this. I hope that I'm preaching to the choir, but people have all kinds of different life experiences, and something that wouldn't affect someone in their experience, that same situation might have a dramatic impact on someone else's life. And so it's not only what happens to us as individuals and what our experiences do, but then we deal with how people respond to us in all kinds of different ways. And so and that isolation and that all of the things that come along with how we let other people's opinions of who we are can have a real impact on our mental health.
So not just examining the staff, but looking at the organization's capacity too, in regards to addressing concerns and issues. Does your agency have a mission statement that incorporates culturally linguistically competence in the service that they deliver? Does your agency systematically review procedures to ensure that they are relevant in the delivery of culturally competent services? Is there a health assessment that's being done or diagnostic protocols? Do you connect with the individuals and people or natural networks that you support or assist or work with? Does your agency conduct activities tailored to engage following diverse communities? So questions that you can ask and this, applies to today's training. Does staff orientation and cultural competency trainings include LGBT population or information? Do your medical provider teams receive training on best practices regarding providing best health for LGBT populations? Are all patients asked sexual orientation and gender identity to show that you recognize the importance of the information? Is sexual orientation and gender identity part of your electronic health records? We're talking about changing, we're talking about being effective and inclusive. Are these things in regards to your tracking data or the number of people that you're serving? Are you partnering with or receiving trainings or making referrals with partners that serve the LGBT population? And then does your staff or health center reflect in regards to the populations that you serve? Are they diverse? Do you have racial ethnic minorities? Do you have LGBT populations that are part of your staff or your governing board or your leadership? So these are things to consider in regards to organizational capacity.
So when we look at the organizational capacity as it relates to, and I'm going to put our work right here in the division, we recently had a meeting with some transgender activists from our community who wanted to speak about how our federal reporting forms were being received by the communities we were serving, because obviously, we receive money from the federal government that then allows us to fund programs out in the field. And so while we need to report out in a certain way about what our activities are and who we have served, and that is defined outside of our state, we took a look at what we could do as far as what we fund in the field to provide people the opportunity to self-identify and to not be forced to be in a bucket like male, female, transgender, male to female, transgender, female to male, and then allow for more open-ended answers that allow them to have their identity, to be recorded as that, but then on the back end for the system to process that in an output way that we can put into the reporting guidelines that we have to meet federally. And so then that allows people to be seen and acknowledged. It allows us to meet the program objectives for our federal partners, while at the same time being good service providers to the communities that are priorities for us. When we talk about diversity and inclusion plans, this is not just a policy. Policies a lot of times sit on the shared drive or in binders on the shelf. But I think that the United Way has done a very good job of making sure their agencies have a high bar to meet when it comes to diversity and inclusion planning. And I'm sure the United Way would be happy to share with people some examples of what they consider robust plans. These are across all levels of the organization. So we talked about that earlier, but also looking at diversity and looking at what the diversity from boards of directors all the way down to the volunteers of the organization, and making sure that every step of the way you have goals that you're setting. And so obviously goals, we're not going to meet every goal that we set, but making sure that we're tracking that and that we're making it a meaningful part of the conversation. And then also making sure that we're advertising our vacancies in culturally competent ways. And so it's not just, throwing something up on whatever that is, one of the major job websites. I forget what the name has slipped my mind. Indeed, like just putting it on Indeed might not work if you're trying to recruit a certain kind of person. And so, having conversations with the people that you serve, so you can say, if I was trying to recruit somebody that would be a good provider for you, where are the kinds of, what kind of websites do you visit? Where do you look for jobs? All those kinds of things to make a good, solid plan and not just a policy.
Jeremy, Antoinette, those are such great insights. And pertaining to the question on recruitment and performance management and the slide that we have up on organizational capacity, we had one of our attendees, Raquel Castro, type in two separate questions. She wanted to give a little background in her organization first. Her organization trains community health workers, and as such, they are trusted members from the community that can help to increase education, access to services, and help support individuals. Her question is two-part. The first part, how can CHWs help support the LGBTQ community? And are there any educational or support curriculums that can specifically help and train CHWs to help bridge this gap?
So when we talk about community health workers, I see a lot of benefit in community health workers for our organization. We're looking at incorporating more community health workers and assisting with retention and care. And so, you know, having people who are those subject matter experts who are familiar with how we can, you know, meet the needs of our clients, having those folks just be involved with retention and linkage. And I think that that's a good good item there. But also, you know, one of the things, particularly in, I don't know when I'm going to work this in, so I'm just going to take the opportunity now. When Antoinette asked me to come, you know, I did have an interesting experience coming out where at 17, my family asked me to leave. You know, I have faced adversities about being queer, but as far as in our community, white cisgender gay men, particularly, you know, people who now get to be in a professional capacity, I don't worry about paying my light bill, you know, all of those kinds of things. I'm not reflective of the people who need the services the most. And so, you know, making sure that we're asking those kinds of questions to Black transgender women who are currently commercial sex workers and they're relying on that in order to survive. Those are the kinds of people that we need to be asking those questions to, because they are the people who need services the most. And so, you know, I think that when we talk about community health workers, and then I would flip that back around and say, how could you imagine using community health workers to serve people who are active commercial sex workers? And what kinds of needs can be met, and what is the scope of service that can be provided by people who our most vulnerable populations work with? And so it's kind of, you know, recruiting, training, and retaining people who can be effective at working in the community with these folks who are at higher risk. And so, you know, as far as, you know, I think that there's just the plethora of services that can be provided are endless. And I don't know if that answer was helpful at all, but I think that maybe reframing the question might allow us to kind of have a thought experiment about how we can employ people in creative and new ways.
I think that's spot on. I think that's such a large and all-encompassing question of specifically how do we create materials and support training across our entire continuum of healthcare workforce to account for not just the support to LGBTQ communities, but specifically understanding the intersectionality of that. And so certainly a lot to be done there, since across the board, I don't know that there's any specific model or specific best practice that's out there outside of what you both have shared very specifically in tactical things, and also in the verbiage to be careful on, and also the way that we can approach it from an organizational and also structural perspective. So I think that's certainly something very interesting. And I will say that as we get into subsequent webinars, we will certainly develop and look at more around the context of how do we create certainly a practice around this that can be utilized as a primer to all organizations to be fully inclusive of not just the LGBTQ+, but also the intersectionality of LGBTQ+ and race, LGBTQ+ and socioeconomic, and all of the other aspects that define who we are and the impacts of how we then care for individuals. I want to thank Antoinette and Jeremy for a fantastic and incredibly engaging presentation. Thank you all for the great materials and insights. Thank you all for attending. stay home, stay safe, and stay healthy.
Yeah.
And wash your hands. Thank you. Take care.